As we introduced at the Museum of Myeloid Art, the myeloid neoplasms are cancers that derive from myeloid progenitor cells. These are stem cells that give rise to the myeloid cell lineage, which includes red blood cells, platelets, monocytes, and granulocytes, such as neutrophils, eosinophils, and basophils. The lymphoid lineage, on the other hand, are your B cells and T cells, but just leave them out of it for now. Lymphoid neoplasms will be covered later on in the unit. In this sketch, the theme is myeloid leukemia, both acute and chronic. First, notice that we have a sanguineous-looking crab plastered on the wall there. That's just to remind you that we're dealing with leukemias. In other words, we're going to see neoplastic white blood cells out in the circulation. In the setting of acute and chronic myeloid leukemia, however, this isn't where the cancer started. To figure that out, we need to head to the bone marrow. Let's start with the acute version. Acute myeloid leukemia, or AML, is caused by a somatic mutation in a bone marrow stem cell, specifically a myeloid stem cell. This cell gets stuck in the myeloblast stage and starts to proliferate like crazy, filling the marrow and blood with millions of immature myeloid progenitor cells. To remember myeloblasts specifically, think of these blasts of spray paint made by this urban artist. Those immature, irregularly shaped splotches of paint are going to be our recurring symbol for immature cells getting pumped out into the circulation before they're fully formed. And because AML specifically involves myeloblasts, which are precursors to granulocytes, we've made the splotches blue, white, and pink to remind you that we're dealing with a basophil, neutrophil, and eosinophil progenitor cell. This disease progresses rapidly, which is why it's called acute. In contrast, chronic myeloid leukemia, or CML, is characterized by the proliferation of more mature cell types, and, as a result, tends to have a more indolent course. So, to convey a chronic indolent progression of CML, we've brought in our recurring chronic grandfather clock. And, since CML involves more mature cell types filling the blood, notice that Lichtenstein's Band-Aid dots are fully formed perfect circles. Just like in AML, we've made the dots pink, white, and blue to remind you that we're dealing with granulocyte progenitor cells specifically. That means immature eosinophils, neutrophils, and basophils. Let's head back to the other rooftop and complete our picture of AML. AML primarily affects adults, with a median age of presentation of 65 years. Why did that one measly stem cell start to go crazy like that? Well, as it turns out, anything that causes damage to the DNA inside bone marrow cell precursors can increase the risk of malignant transformation to AML. This includes exposure to chemotherapy, which is usually designed to cause damage to DNA. As you might expect, the resulting neoplastic cells often have mutations, deletions, or translocations. On the test, the classic clinical vignette involves a patient with a history of some other form of cancer, who was treated with chemotherapy and is now presenting with symptoms and signs of acute leukemia. Another risk factor for AML is ionizing radiation, which also causes injury to DNA. Look out for the atomic bomb survivor, or the wayward radiology technician who eschews precautions, resulting in chronic exposure to radiation. Here's a weird one. Exposure to high levels of benzene, which can happen to employees in the plastics or rubber tire industries, will also increase one's risk for AML. In children, especially young kids, Down syndrome is associated with an increased risk of developing AML. And finally, we've included the MoMA, the Museum of Myeloid Art, to remind you of our previous sketch. All those myeloproliferative disorders we covered, including polycythemia vera, essential thrombocythemia, primary myelofibrosis, and CML. Check out our myeloproliferative disorder sketch for more info on these conditions. But as a little extra reminder, we've put some pink, white, and blue balloons being sent up in the air to depict the proliferation of myeloid cells. Remember that means eosinophils, neutrophils, and basophils, along with their precursors. Clinically, the name of the game when it comes to AML is cytopenia of one or usually multiple cell lines. At Sketchy, an empty pan symbolizes a complete pancytopenia. But here, let it remind you that multiple cell lines can be affected. Think thrombocytopenia and anemia. Now, the overall white blood cell count may actually be high due to the proliferation of all those myeloblasts we mentioned. But for all intents and purposes, there's a functional neutropenia. By that I mean, your white cell count on labs will measure high, hence the accumulation of white doves on the rooftop there. But the number of mature functioning neutrophils is probably low. What you're really counting are all those blasts, which are taking up all the room in the bone marrow and inhibiting normal cell production. The initial clinical symptoms are related to the complications of pancytopenia. Just take a look at this apprentice over here, taking a nap after a long day of inadvertently inhaling spray paint fumes. Anemia can lead to weakness and fatigue. Fever is another common presenting symptom, and is usually due to infection. Remember, we don't have many functioning neutrophils anymore. In a small minority of patients, the fever is actually due to the AML itself. On the skin, look for petechiae and ecchymosis, a sign of bleeding due to thrombocytopenia. As we've mentioned, the characteristic feature of AML is the presence of myeloblasts in the bone marrow, and often in the peripheral blood as well. To diagnose AML, blasts must account for at least 20% of bone marrow cells, or 20% of peripheral blood cells. Notice that the satellite dish forms the number 20. On histology, myeloblasts are large cells with abundant basophilic cytoplasm, often with faint granulation. Myeloblast nuclei are often folded or bilobed, containing multiple dark nucleoli. In some AML subtypes, the cytoplasm of these myeloblasts contains pathognomonic hour rods, pink rod-shaped structures that stain positive for peroxidase. In this scene, just some peroxide paint remover. Hour rods indicate partial myeloid differentiation. In other words, these cells were destined to become granulocytes before getting sidetracked. Hour rods are particularly prominent in the pro-myelocytic subtype, but they're not present in every case of AML, namely those containing cells other than myeloblasts. This includes erythroblasts, monocytoblasts, or megakaryoplasts. These are all non-granulocytic precursors, though they still count as myeloid cells. Regardless, if you see hour rods, think AML, because they aren't present in any other type of leukemia. Speaking of subtypes, let's pause for just a second to mention that there are a number, 8, if you were wondering, of different subtypes of AML. However, since most of them are so rare and not tested, we'll take a moment to go over them in general before diving into one subtype that you do have to know something about. For the most part, the different subtypes of AML are divided by the type of cell that predominates, such as the myeloblast, erythroblast, monocytoblast, or megakaryoblast. The myeloblastic subtypes are by far the most common, comprising up to 50% of all cases of AML. Acute promyelocytic leukemia, or APL, is characterized by the presence of promyelocytes, an immature form of myeloid cells that typically contain lots of hour rods. Notice the pro shirt worn by the jock here, who's found the perfect makeout spot on the rooftop. Nice. As you know, AML is associated with acquired mutations that result in inhibition of myeloid cell differentiation. They get stuck in a blast phase. Well, the APL subtype is no exception. The APL subtype contains the T1517 translocation, which results in fusion of the retinoic acid receptor alpha, or alpha-RARA gene on chromosome 17, to the PML gene on chromosome 15. Believe it or not, this is all symbolized by the high schoolers playing tonsil hockey. For 1517 translocation, imagine that they're high school age, so about 15 to 17. And he's translocating his Letterman jacket onto her shoulders, if you will. What a gentleman. For RARA and PML, see the words Go Pro on his sports shirt and Rah-Rah on her cheerleading outfit. The resulting PML RARA alpha fusion gene codes for an abnormal retinoic acid receptor, stopping myeloid cell differentiation at the promyelocytic stage, and leading to an abundance of promyelocytes in the bone marrow and peripheral circulation. In acute promyelocytic leukemia, promyelocytes may secrete tissue factor into the bloodstream, leading to that dreaded condition called disseminated intravascular coagulation, or DIC, symbolized by a recurring DIC dice. DIC is incredibly dangerous and carries a high mortality rate. Look out for a wacky paradox of both hypercoagulability and bleeding. And be sure to check out our acquired coagulation disorder sketch for more info on DIC. If I roll snake eyes, then we get to use tongue. Ah, man, the memories. If I had $1 for every high school football player who asked me that, then at least I'd have gotten something instead of regret. But yeah, the APL subtype can be aggressive. In fact, it's considered a medical emergency with a high rate of mortality. Fortunately, APL also happens to be one of the most treatable forms of AML. Treatment regimens include all-trans retinoic acid, a vitamin A analog, hence the assistant Captain A on his jacket, All-trans retinoic acid works by signaling those neoplastic promyelocytes to differentiate into neutrophils, which have a limited lifespan and are removed from circulation after a short time. Treatment for AML in general relies on chemotherapy, and the prognosis is often poor. In some cases, a bone marrow transplant can be curative. Well, that's it for acute myeloid leukemia. Let's shift gears and talk about chronic myelogenous leukemia, or CML, a completely different condition that has an altogether separate pathophysiology. As you might recall from the prior sketch, CML is a myeloproliferative disorder. Also, remember that Lichtenstein over here specializes in the use of Bende dots, those perfectly round, fully formed circles of color. It should remind you that CML results in the proliferation of more mature cell types. We're not stuck in the blast phase anymore. AML and CML do have an important thing in common. They both occur in older adults. The average age of presentation is about 60. Exposure to ionizing radiation is the only known risk factor for CML. So once again, look for that atomic bomb survivor or that wayward radiology tech. CML arises from an abnormal bone marrow stem cell that has acquired the BCR-ABL fusion gene, usually as a result of the balanced reciprocal translocation that moves the ABL proto-oncogene from chromosome 9 to chromosome 22, adjacent to the BCR gene. This translocated chromosome is known as the Philadelphia chromosome. While the BCR-ABL fusion gene is always present in CML, it can also occur in other forms of leukemia, such as AML and ALL. Interestingly, neither BCR nor ABL have intrinsic oncogenic properties, but together they become unstoppable. Why is Lichtenstein dangling from the tire swing, you ask? Well, like the other myeloproliferative disorders from our myeloid museum sketch, think tyrosine kinase. The fusion of BCR to ABL produces a constitutively activated receptor tyrosine kinase, to be exact. This leads to uncontrolled production of granulocytes. On labs, this shows up as an increased white count, leukocytosis, in other words. Not B cells and T cells, mind you. We're talking neutrophils, eosinophils, and basophils. Hence the whole pink, white, and blue theme. Both mature and immature granulocytes are produced. Immature cell forms include promyelocytes, myelocytes, and metamyelocytes. Okay, I admit, you might see some myeloblasts too. But if these are present, there are usually only a few. Like, less than 2%. Myeloblasts are the hallmark of AML, not CML. To help you remember the sequence of granulocyte development, we have myeloblasts as a part of the AML section on the left. Then as we become more mature to the right, we can see the promyelocyte pro-Gym, the myelocyte myelomol, and the metamyelocyte metalco. Notably, myelocytes are usually present in greater numbers than the more mature metamyelocytes, a phenomenon known as the myelocytic bulge. So we've made the myelomol the tallest of the bunch. In the setting of CML, platelet proliferation is also common, leading to thrombocytosis, hence the stack of platelet paintboards. Just like we illustrated at the myeloproliferative museum sketch, this doesn't necessarily mean increased thrombosis, though that is certainly a risk. It turns out that when there's an overload of platelets in circulation, you use up all your von Willebrand factor, which can increase the risk of hemorrhage. So remember, myeloproliferative disorders, including CML, can cause both thrombosis and bleeding. Red blood cells are not part of the proliferation lineage, and as a result, a normochromic normocytic anemia is often present in patients with CML, as symbolized by Lichtenstein's anemic-looking smock. All right, let's see how this whole thing progresses. Remember that chronic grandfather clock? Most patients with CML present in the chronic phase, with insidious onset of symptoms. As with many other cancers, fatigue and weight loss are common signs. Because the bone marrow is chock full of neoplastic cells, there isn't much room for producing red blood cells. So hematopoiesis jumps out of the bone marrow and into other organs, such as the liver and spleen. This is called extramedullary hematopoiesis, and it can lead to splenomegaly, which manifests as abdominal fullness. There may even be splenic infarcts due to insufficient blood flow to the superlarge spleen, resulting in left upper quadrant pain. Over time, CML progresses to a more aggressive accelerated stage, in which cells become more immature and therefore more abnormal, with more myelocytes and fewer mature cells. As a result, platelet proliferation decreases as well, leading to thrombocytopenia, a big change from the thrombocytosis that characterizes the chronic stage of CML. And finally, see that blast of spray paint? Ultimately, CML progresses to the blast crisis stage, with rapid production of myeloblasts. Sound familiar? Pathologically, this stage of CML is quite similar to AML. And as you might imagine, it's a lot more difficult to control the cancer when it reaches this stage. Thankfully, CML is actually treatable. Due to the availability of targeted tyrosine kinase inhibitors such as imatinib, dasatinib, and nilotinib. All these nibs, remember, are symbolized by the pen nibs. These inhibit the constitutive tyrosine kinase activity of the BCR-ABL protein, resulting in long-term disease suppression. In addition, hematopoietic stem cell transplantation is curative. Before we go, we should mention a benign condition, leukemioid reaction, which is characterized by a white blood cell count of greater than 50,000. Just look at all those white doves accumulating. Almost Hitchcockian. The reason we need to bring it up now is that CML also causes increased amounts of mature white cells in the blood. So how can you tell the difference? During a leukemioid reaction, which can occur during times of stress or infection, the white blood cells out in the circulation are composed mostly of neutrophils, as depicted by our recurring neutrophil EMTs, the first responders of the immune system. You should see some immature neutrophils out there as well. These are called bands and are represented by the bandages on the patient's legs. Also, you see how the weight is starting to shift toward the left? When more bands are present, this is called a left shift in the white blood cell distribution. You might even see earlier precursors, such as myelocytes and metamyelocytes, but these are rare. The way to tell CML and leukemioid apart? Well, functional neutrophils produce an enzyme called leukocyte alkaline phosphatase, represented here by the ALK-Phos chalk. In the event of a leukemioid reaction, expect to see normal or elevated leukocyte alkaline phosphatase activity. In CML, this enzyme is low because the neutrophils created by CML bone marrow are abnormal and non-functional. When you see leukemioid reaction, the question stem will probably mention a history of a recent infection or other signs of infection. Sometimes you can even tell some kind of infectious process is going on just by looking at the neutrophil. Typical histologic changes include toxic granulation, cytoplasmic vacuoles, and these little peripheral light blue spots called Dolly bodies. And that about wraps it up. Before we move on, though, the grand summary. AML is more acute and rapidly progressive. And I don't mean progressive like Banksy. I mean progressive like it can be a medical emergency with high mortality. CML, on the other hand, is more chronic with an indolent course. In AML, you have a bunch of myeloblasts, which are very early granulocyte precursors, while in CML, many more mature granulocyte forms are produced. This includes promyelocytes, myelocytes, and metamyelocytes, as well as mature granulocytes. Immature splotches on the left, more mature circles on the right. Both AML and CML commonly present in patients around 60 years of age. AML starts with this weird PML-RARA translocation, while CML is kicked off by that wacky BCR-ABL fusion protein, a constitutively active tyrosine kinase. To diagnose AML, you need to see 20% blasts in bone marrow or circulation. Myeloblasts are big, basophilic, granulated, and with or without hour rods. When the marrow gets crowded enough, a pancytopenia occurs. Though white count will be high, because of all those blasts, remember those white pigeons or white count, the actual amount of functional neutrophils is low. So really, all cell lines are down. CML is different. While patients often present with anemia, as depicted by Lichtenstein's pale anemic smock, other cell lines can be elevated, including platelets and white count. The white count is due to all those mature granulocytes floating around, mostly in the neutrophil series. Watch out though. CML can hit an accelerated stage of greater immature myeloblast production, culminating in a blast phase, which looks like AML. And that's all she wrote. For a more complete picture of how AML and CML fit into the entire spectrum of myeloid neoplasms, check out our myeloid museum sketch. You know, we've been harping on about myeloid this and myeloid that. Well, it's time to talk about that lymphoid cell line for once. Next, we present the lymphoid leukemias, ALL and CLL.